Welcome back. I'm pleased to be joined by Erin Holvey and Pat Gleason, who I'll introduce in a moment. I want to thank everyone for joining us this morning and again express my deep appreciation to our wonderful patient panel and moderator. They really set the stage for, I think, what will be our key focus today, which is ensuring that we're incorporating patient perspectives and inputs and preferences into value assessment and ensuring that our healthcare system is more patient-centered. So now we are going to pivot and hear in a moment from two key stakeholders in the healthcare ecosystem. Erin Holvey is Director of the Department of Healthcare Finances, Healthcare Reform, and Innovation Administration within the District of Columbia government, otherwise known as DC Medicaid. In this role, Erin creates and tests new delivery system and payment models among Medicaid providers in the district. Dr. Holvey has more than 20 years of experience in health policy and health services research with extensive experience in healthcare access and health system transformation. Prior to joining DC Medicaid in 2016, she served as a senior director at Academy Health. Her experience includes promoting innovative uses of health data to improve quality and drive healthcare reform. It's great to have you here this morning, Erin. Pat Gleason, great to see you, Pat. Pat is Assistant Vice President for Health Outcomes at Prime Therapeutics. Pat has been with Prime Therapeutics for nearly 20 years. In his role, he leads pharmacy outcomes research. Pat has experience as a clinician and as an adjunct professor at the University of Minnesota, advising PhD students and mentoring pharmacy students. And just a personal thanks, Pat, for that role that you're playing in supporting the next generation of healthcare professionals. That's incredibly important, particularly as we face shortages and strains on the healthcare system. So thank you both for being here this morning. Before we jump in, I know I just gave your bios, but I think it would be really helpful for everyone to hear from each of you just a few minutes about really what's your day job? How do you spend your time? And how does that intersect with the things that we're talking about this morning? So we'll start first with Erin and then we'll go to Pat. Thank you.
Well, good morning, everyone. Thanks, Lisa, for facilitating this panel, and IVI and PCORI for this great opportunity to discuss such important issues. I have a really unique and interesting role within DC Medicaid. And as you said in your overview and bio, Elisa, I've worked in a variety of different environments, from federal healthcare to nonprofits, and with HRQ on a lot of the work with the Electronic Data Methods Forum for many years at Learning Health Systems. And I would say that in my day-to-day, all the things I've ever worked on come to the fore. So whether it's a matter of doing analysis, looking at our claims data, thinking about the design of new projects and programs as we are right now with the American Recovery Plan, home and community-based services funding that's available to state Medicaid agencies, to contemplating a variety of different, privacy issues around, use of data for various purposes, programmatic research, et cetera. It's a whole potpourri. So everything from, again, policymaking to analysis, including, advising on some coverage decisions. So it's a very exciting and dynamic role, and I'm looking forward to the discussion. Thanks so much.
Thanks, Erin. I have a quick question, which is how often do you actually get to talk to DC Medicaid beneficiaries?
Well, so that's a great question. Sometimes there are folks actually who miss the call center and end up chatting with me about some of their, sort of coverage determinations, and I direct them to the right case working folks. But, since the pandemic, it's been tougher. There are community groups that I engage with regularly. Typically more, as intermediaries now, but try to get out into the community, certainly pre-pandemic as much as I can. And, I'm actually, the only reason I'm at home today, we're back in the office, is because a pipe burst right above my office. And so,
oh no.
now we're back at home. So good thing we know how to do it,
Seriously. Well, we're glad you're with us, and thank you for the role you play. I'm no longer a DC resident, but I was for a very long time, and very much appreciate your public service. So thank you. Pat, tell us a little bit about how you spend your days.
Sure. Thanks for having me. Pleasure to be here. I'm in flyover country, so I'm in Minnesota, where Prime Therapeutics is headquartered. Um, Briefly, I want to spend a minute just to explain who I work for, because many of you may not have heard of Prime Therapeutics. So we're a pharmacy benefit manager. I know I saw in the chat, avoid acronyms, doing my best here, but I will say pharmacy benefit manager. And from now on, I'll probably say PBM. So PBM owned by 19 nonprofit Blues plans. We have a unique ownership structure. It makes it possible to remain absolutely committed to the health of our members we serve. Prime Therapeutics manages pharmacy benefits for about 33 million Americans throughout a relationship with our Blues plan owners and health plans, employers, and government programs, including servicing Medicare and Medicaid. We believe in a health benefits landscape founded on fairness, focused on outcomes. So with our 19 Blues plan owners, we provide total drug management. I actually daily look at integrated medical and pharmacy claims data, meaning drugs that are processed through the medical and pharmacy benefits, comprehensively looking at and doing our best to ensure the most appropriate, most optimized drug therapy and the most cost-effective therapy is being provided for our membership on behalf of our Blues plans, and most importantly, continued access. I've heard access, mentioned a number of times in the previous panels and presentations. Couldn't agree more. Part of my job also is to forecast new gene and cell therapies and new drug therapies coming to the market, frankly, to ensure we can afford them and pay for them. They come in at a very high price tag with generally very little data. And I'm just really looking forward today to learning more about how we can, as Prime Therapeutics, and as part of my role in assessing, doing an economic assessment of drug therapies and presenting that to our external pharmacy and therapeutics committee. That's the body of physicians and pharmacists that are external to Prime, by the way, that make decisions of coverage and formulary direction for us for the access to these medications on behalf of our 33 million Americans for which we're providing these services. So I'll look at items like I heard mentioned earlier, by the sickle cells representative, like the ICER report, the Institute for Clinical and Economic Review, which, by the way, is the only neutral body out there assessing the cost effectiveness and value of a pharmaceutical, and very frequently, and other therapeutics as well, very frequently find they're overpriced to the value. I'm sure we'll have many more questions for me on that from the panel and those here.
And we have limited time. That could be probably a whole day discussion there, Pat.
Perfect.
So thank you, appreciate it. Well, great. Thank you so much for level setting and ensuring that everyone participating today has a glimpse into how you spend your respective time in your position. So reflecting on the really terrific opening panel discussion that we just heard, I'm curious to hear what part of that discussion really resonated with you, and how does what you heard from our patients align with either discussions that you're having within your respective organizations or decisions that you are faced with making on a probably daily basis. So Erin, do you want to start?
Sure, thanks, Lisa. So one of the things that I neglected to mention in my overview, so two key pieces of information that relate to the panel's comments. So one is that while our Medicaid program in DC is a bit smaller than some other states, we have the unique feature that we have the second highest rate of insurance coverage of any state. I'll say state.
You can say state.
Yeah. In the country, second only to Massachusetts. And so we actually now, particularly post or throughout the pandemic, insure about 300,000 folks. And we cover about 4 out of 10 district residents overall and 7 out of 10 kids. So when you think about what the potential is for public insurance to really advance our both sort of health improvement and outcomes objectives, and really to address equity, Medicaid is in a unique spot. One of the other hats that I wear in my role is chair of Mayor's Health Information Exchange Policy Board. And so I was particularly struck by Hugo's comments, the story of the 3 portals, as I was thinking about it, Hugo, as you're telling
Right.
it. And so one of the things that we are really focused on right now that I think relates to many of the comments that the panelists made is really creating what we refer to as a health data utility in the district. So trying to make sure that no matter who you are, no matter where you go to get care, all of your information is available through the Health Information Exchange. And so the DC Health Information Exchange, the DC HIE, as I'll refer to, is really achieving a lot of those objectives by trying to make sure that we're using consistent data standards and trying to actually move interoperability and patients access their own data into a sort of common utility data stream. And I think that the opportunities that gives us relative, particularly to some of the comments that Mariana was making, right? I was really struck, the time and control, for A1C is such an important measure. And I was really struck that I think that's what, as we see all of this data come together into this common utility model,
Right.
one of the biggest opportunities I think is looking at those temporal measures. Because we don't have sort of pot shots of data, right, or have to average information anymore. We can really have confidence that we're looking at information for the whole person. And that same thing is true, by the way, for patient-reported measures and as well as satisfaction and sort of experience in the healthcare system. So there was a lot of great takeaways in the panel that it really is highly related to the work that we're doing at present.
That's great. Kudos to you for trying to get it all in one place. When Hugo said, 3 different portals, I had a lot of empathy for him. I think we probably, between, my family and my parents, there's probably 12, and I've lost track. So appreciate that.
Clarify though, yeah, Lisa, I should just clarify that, our objective, right? I think this is the marvel of modern data analytics. We actually don't have to have all the data in one place, right?
Right.
It has to show up in one place, be
right.
in one place. And I think we now have the right opportunity to do that.
That's great, Erin. Pat, reflections on the panel vis-a-vis your work.
Yes, I very much appreciate what Maggie had to do and commiserate with her pain of costs. But I will say that that $60,000 was a very good investment, and I would encourage all other patient advocacy groups to participate with ICER and help them. That's the Institute for Clinical and Economic Review, as they do a drug class review. And the sickle cell disease drug class review, we look at that, we use that information in formulary decision making and prior auth step therapy criteria development. It is incredibly beneficial to receive and have the patient voice in that process of the ICER and the Institute for Clinical Economic Review with its public review process, exceptional. So thank you, Megan. I know it's hard and I know it was painful and costly, but I will say that I look at that. Productivity was included, school attendance, caregiver burden, those were all monetized. And that's the other piece of things. It's very hard, and I know it's hard to hear, but the monetization of these points to include in a model, it's helpful. It's very helpful. So thank you on that. And if you give me a little more leash here, Lisa, I'll bring up, the glucose monitoring. Couldn't agree more. I mean, we're covering our continuous glucose monitors. So thank you, Annie. I think it was that provided those insights. Maybe it wasn't Annie. Apologize.
Mariana. Yeah.
Mariana, thank you. Yes. And I'll just continue on that thread. Data is really important. Digital therapeutics now, as we look to cover them more and understand their value, I'm looking at that piece of the puzzle is actually solving maybe the puzzle of collecting patient-reported outcomes in a way that we can get that information into the health payer space so that really important, we can use that data. I'm looking and very excited by to both contract with the provider for a value-based contracting at the provider level and with the manufacturer as an individual that does negotiate with manufacturers for value-based purchasing agreements. So this might be the avenue that data can be brought in on the patient preferences and outcome measurement.
I appreciate that. And that's a great segue to the next question that I had teed up, which I'm going to tweak slightly. So the question I was prepared to ask, which is what data are the most relevant to, key decisions, and to use kind of a term of art within value assessment, fit for purpose, right? And from, with respect to from where you sit, but I want to amend my question by saying I really heard from the first panel the concern and frustration and limitations of only looking at claims data, right? Maggie in particular highlighted, and if you had a chance to look at the case study, and I hope people really take the time to look at both case studies, but she highlighted that so much of the care and treatment for sickle cell disease occurs outside of the traditional medical care system, right? It's home remedies, it's probably things that maybe aren't covered by your health plan, and yet those are incredibly valuable. And there's, potentially a burden of seeking those different interventions and a cost associated with it, but also a value. And so as you think about the data that are most important to you, I ask that you respond to the comments about the limitations of just looking at claims data, and then also give us a flavor of, from a 360 view, what other data are most useful in your work. And let's start with Erin, and then we'll go back to you, Pat.
Well, I was going to say, since Pat's mentioned the Institute for Clinical and Economic Review, I'd love to hear, Pat, maybe your thoughts first, and then I'm happy to add on some clinical data.
Yeah, I'm very much limited by the data that I can get my hands on, and that currently is really claims data. And I agree, claims data are very, very limited in their ability to assess comprehensive patient outcomes. They can't. I can't see, and I heard mentioned, there should be coverage for and pay for OTC, over-the-counter drugs and other remedies. The hard part there is, A, it's not submitted as a claim and part of the insurance coverage, and then B, we need to do an evaluation of effectiveness and safety, especially for home remedies, and we aren't able to do that. So that's challenging for us to feel that it is coverage of something to cover without knowing its safety and effectiveness. Yeah, I'll go back to the place that the path forward in my mind of data collection is through digital therapeutics.
Thank you for that. Appreciate it. Erin.
Yeah, and I'll pick up on Pat's point about digital therapeutics, which is really taken. HRQ a number of years ago did a very helpful review on N of 1 studies, and then the concept of many N of 1 studies. And I think we do see a lot of digital applications essentially facilitating, those type of N of 1 studies where someone uses their own control in a structured way. I think the methods haven't come quite as far as they need to, because I think, again, what I think we're inherently talking about is what's the mix of patient-reported outcomes, the digital therapeutics, right, that gives us this fuller picture. And what that we're really taking a close look right now at is that we have a very progressive framework around telehealth coverage. So we pivoted very quickly during the pandemic to allow home to be an originating site for patients, and to do a lot of other, I think, very progressive work in that space. However, a lot of the sort of full range of e-consult services that would create the care delivery system connected to the digital therapeutics, I think is still evolving and emerging. And so the ability to really study and understand what the best sort of structure of coverage and care and services is, I think is really important. And a good example for folks to chew on, because it's an important edge case, I think, is telemedication assisted therapy for folks with substance use disorder.
Mhm.
There's a big ongoing discussion about, can you do induction of telemedication assisted therapy, particularly buprenorphine, in sort of perpetuity. It was allowed during the pandemic, but how are we going to sort of, are we going to continue that framework for telemat? Are we going, and then how do you make sure that the appropriate therapy is happening alongside those services? So there's some really interesting medication delivery technologies that are now being tested with NIH and a number of other areas. But again, I would just go back to this idea that it's the combination of services plus therapeutics that I think we need to be talking about and measuring as well.
That's great. So I'm hearing a bit of a theme here. So that claims data is helpful, but not enough. It only tells us what people, I think Dana Saffron said it, right? In a fee-for-service system, what did you get? Who got it? What did you get? How much did it cost? And where did you get it, basically, right? I'm simplifying it, but that's kind of claims data, right? And why did you get it? What was the diagnostic code, right? So we need that, because that tells us at least something about what's going on, plus digital data from digital therapeutics, plus some patient-reported outcomes. And then all of that needs to be within a scaffolding or mixed in with the ingredients of really understanding patient preference and patient priorities, right? And we're not there yet. That's the goal, but it sounds like we at least have some consensus that that's where we need to be, and that what we have today is not enough. It's not sufficient.
And comments on that?
Please, yes.
Piece, which is patient experience, right? So
yes, thank you. Absolutely.
Particularly as we talk about doing a better job addressing equity issues.
Yes.
I think the National Academy of Medicine's white paper from a couple weeks ago on addressing measurement and equity really, shows the Press-Ganey scores that show incredible differences for people of color, particularly, Black and Latinx patients. And we have to tackle that issue, both with better data as well as incorporating that data effectively into measures.
That's a great point. Thank you for raising that up. Incredibly important. I had a lot of questions to ask, but there's so many terrific questions coming in. I'm going to take the moderator's, prerogative here, and I'm going to pivot and start to ask some of the great questions that have come in. And thank you to our participants, and keep them coming. So here's an interesting one, just on the point where we were talking a moment ago about home remedies and over-the-counter, Pat, to your point. There's a question here about, could we get any data or line of sight based on claims from either health savings accounts claims or flexible spending account claims? Thoughts on the utility of that, whether or not that would help us at all?
Well, I can just say I currently don't have access to that data.
So if we could get you access, then maybe.
Maybe, because I don't, the detail generally, to my knowledge, there's a dollar amount and there may be a name, but then, what is that isn't codified into a chemical entity that I can then do analytics on? I mean, I'm a health service researcher by training too, not just a pharmacist. So I when this comes down to it, it's unstructured data or structured data, and you really need structured data to do analytics. So I'd say that's going to be challenging, but I'm not going to rule it out, but that is not something that will be easily done in the near term. Gotcha.
Thank you. Erin, did you want to hop in on that?
Yeah, the dimension that I think this is a really interesting idea. I'm trying to sort of suss out or how we would incorporate some of the data feeds from, the HSA or FSA benefit providers. So if anyone has ideas on that, I'm all ears. And there's some contracts, but they're sometimes sort of misaligned. So I'm just trying to think about how we work those levers. But the other thing that hasn't been talked about as much, I think, is we have all of these health home programs now, right? More advanced care management programs. And, the intake and assessment for those programs is really extensive. And I'm not saying that everyone has access to them,
Right.
but I don't think we use the information from those assessments and
Mhm.
plans nearly enough. And so, one of the things we're trying to do is integrate those care plans. Well, first of all, to automate them more effectively. That's been an ongoing discussion because there aren't a lot of EHR modules that actually, sort of natively
Yes.
have those care planning tools in them.
Right.
So it's a little bit tougher to do what you were describing, Pat, which is to have the structured data that those might generate. But at minimum, what we're trying to do is make sure that those documents actually enter the data stream with the health information exchange. And
Mm-hmm.
this is an area that would be interesting to continue discussing because a lot of these types of therapies or, sort of additional over-the-counter approaches are actively discussed by those care coordinators and care managers. And I also think it's really important that those assessments, those types of structured assessments, really are one of the best pictures we have as a payer, with our providers, working in concert with our providers, of what the patient's primary goals of treatment are. And again, I think we probably just don't do enough with that information. I
Right.
want to make sure that we had consent to use the information as a payer,
Mhm.
but it's there, right? And
Right.
I think increasingly could be collected in a more structured way.
That's great. And that's actually a great segue. I was listening to you and monitoring the chat. I'm a mom of twin boys, so I can sometimes do two things at once. And I wanted just to honor and acknowledge some great comments here about the difference between, or the focus rather, on data and the questions we should be asking. So I think there's some really important comments about, we can have all this data, but if we're not asking the right questions kind of at the top, if you will, the data are not going to be particularly useful or meaningful. And I think your point, Erin, about when we do an intake or an assessment, we often talk to patients about what are their goals, right? If clinicians have goals, but patients and caregivers and family members have goals too. And so if we're starting at the top, if we think of it as kind of a funnel of data, if we start at the top with the right questions that are patient-centered about patient preferences and priorities, and to your point, experience, right? What do they hope their experience is? And then ultimately, what was the experience? And is there a difference between the two? And then we have to address those disparities and inequities, right? But getting those questions at the top right will then result in, a cascading set of data, hopefully, that will be more meaningful. Just reflections on that. I see, Pat, you're nodding, so I don't know if you want to hop in here.
I couldn't agree more. I mean, that is I would say that from the insurer standpoint, that's
Mhm.
when it comes to devices and drugs, those are the endpoints then that are really essential to be in those clinical trials so that they can be measured and then shared with us as to these are the endpoints that patients want. And we have measured them and we're showing that our given therapy is achieving those, thereby insurance coverage should be provided. I'm on board with that.
That's great. Thank you. Erin.
Yeah, and of course, I absolutely agree. I mean, I think a lot of, infrastructure is not always sexy, right? So
Right.
But, a lot of the work that we're doing right now is to get the right governance structure in place that will leverage particularly the interoperability and patient access rule so that we can have more data to drive these discussions. So it's interesting. I noticed the comment from, I think it was an anonymous attendee, at least right now, as listed, about the idea that none of the discussions start or include patients or patient orgs. And that's absolutely not the case for DP at least. We often hear about their proposals for new therapies that come out of our ongoing involvement with advocacy groups within the district or with individual patients. There are a lot of different ways that requests bubble up. I think the challenge from my perspective is that, and perhaps some of the other comments in the chat, unless those organizations are bringing data with them, the conversations are inherently more political and budget-based than evidence-based, right? And so I think we have to kind of, pay attention to that dynamic as well, particularly when it comes to public insurance, right? Because there are inherent trade-offs, right? When we do our budget planning cycles, unfortunately, it is the nature of, public budgets, right? That $1 in one category, even if we can extend it with our federal state partnership for the Medicaid program, are resources that, can't go to another program. So we're going to need to continue to have these discussions and really make sure that our decisions are evidence-based. And again, that's why I emphasize the linkage of what the service is, and not just as particular therapy or intervention, because or innovation, because there's just no doubt that we have to look at sort of the whole picture of coverage and really make sure that we're creating the right incentives for that value-based paradigm.
Right. No, I appreciate that. As somebody who's been engaged in federal budget and appropriations work for the past 30 years in my career, the budget realities that face all of us, but particularly, public programs, I know is an ongoing reality and strain. I did want to, though, spend a minute or two talking about this. I'll just call it maybe a seesaw or a tension, right? So the patient groups that we heard from, a lot of them are busy trying to collect the data, trying to advance understanding and knowledge. I gave my example of the SMA patient, earlier. That was amazing work that was done by the SMA community a number of years ago. And, today we just heard from 4 patients. There's dozens and dozens of other patient advocacy organizations for, innumerable diseases, conditions, and disorders and disabilities. But as we're just talking about limited resources. These are 501c3 organizations. They have limited resources too. And we have a comment/question here about, the cost of this, right? The cost of doing this work shouldn't be totally borne by the patient community. And I think what we're trying to get at is, what are the right partnerships? There's lots of us in the ecosystem. How can we pool resources, both fiscal and, and knowledge and expertise, to advance this in a way that we are asking the right questions, collecting the right information, and doing so in a way that doesn't burden any one entity unfairly in the ecosystem. So Erin, do you want to start on that?
Well, sure. I'll start with the point that I think is a recurrent theme in my comments, which is, a lot of my role right now is to try and bring the cost of gaining access to that data down. And I think I can do that. It requires consistent pressure, I think, by a lot of payers and purchasers to ensure that we're collecting, data in the right ways, using national standards, et cetera, right? But, really the capabilities to move information, to present it in different ways, I think they can be lower than they are right now. And I think part of our role as a public payer and partner with the Centers for Medicare and Medicaid in looking at both claims data, but also, in reporting back to CMS, to try and make our data more accessible. So I think that's one piece of it. And we actually have established over the last couple of years, I've established a partnership policy for the agency, and would encourage anyone who's looking at key questions or services in the district to take that page and think about ways that that our resources could help make the case or support some of those efforts. And again, that evidence base. So I think there are lots of opportunities, but I think we need the right framework for partnership, and and to recognize kind of what role or sort of unique assets each of us has.
Great, thanks. Pat, I know you earlier mentioned that you only, the data is only as good as you have access to. So curious to hear your thoughts on partnerships and ways to expand the data set and to do so in a cost-effective manner for all the stakeholders.
Personally, that's not piece that I'm involved in. So I mean,
It's okay.
I'm not on that end of it. I will say that I'll work with any data that we can get access to. It's very challenging to get data. I'm currently working with our Blues plans to receive laboratory data, for example. Some of them also are receiving access to the electronic health record, and that's going to be a pipe that we look to build from the Blue Plan to Prime Therapeutics to have access to that as well, to inform and best measure the value of a given therapeutic for then coverage determinations, and also to expedite and make it easier to work through. And I know they're onerous, but the utilization management med policy processes that exist, and we're trying to get a turnaround time here of less than 24 hours all the time for the coverage determinations, as we strive to do. And I'll sort of, I mean, I'm sorry to keep coming back to, but I do think that the digital therapeutic entities, especially in more of the chronic conditions, and I appreciate that for rare orphan conditions, this is not going to be as easy, but for diabetes and some of the other, very common chronic conditions for which there are many digital therapeutic entities out there, some of which very questionable quality. So I would actually, my request of the patient advocacy groups is to help us identify good partners with digital therapeutic offerings where data can be collected on patient preferences and then inform. And I saw in the chat, the continuous glucose monitoring and ensuring, how is the insurer helping to help the patient here? Well, we could work together here if we could agree upon what is a digital therapeutic entity out there for diabetes and the service offerings that they can provide at a fair price. I mean, there's a fair amount of markup here in this space too.
Thanks for that. I'm just minding the time, and I see two really good questions I want to make sure we get to. So this one is for you, Pat, so we'll stay with you. It says, appreciate your comment about the SCD community engagement during the 2019 ICER review. Using this report as an example, can you discuss elements of the patient perspective that were helpful for your organization and your decision making, and what kind of an impact has it had on these types of decisions?
Well, it is a point of discussion that occurs that wouldn't occur at the Pharmacy and Therapeutics Committee meeting. So without that report and the information included in it on patient preferences, we wouldn't have the conversation. So I will say that it allowed.
So it's a catalyst for that conversation.
Absolutely.
Like.
Okay.
Got it.
And then, but I mean, I have to say, the drugs are priced at $100,000+ a year for the therapy, and their outcomes data is not great, frankly. And so they're still very overpriced value. This is the challenge in America. I mean, I heard Hugo complain, and I get it, about his $9,000 that he has to pay to get access to health insurance. But one of the reasons, Hugo, you're paying $9,000 is because there are some, in America, we are charging much more for the same therapeutics in other countries.
So Pat, I appreciate it. I think drug pricing will be a different summit on a different day. Okay. I want to honor, the issue, but let's, we got to stay in our own lane. Otherwise, we're gonna. I'm going to get a big hook from Jen Bright at IVI.
You can't ignore the pricing and fair.
No, I want to honor the comment, but drug pricing is a big issue for another summit, another day. So I do want to make sure that people are submitting their comments, and in particular, there's another one on ICER that I wanted to get to here. I'm just scrolling to see. It disappeared. So I guess maybe someone felt we answered it, which is great. So here's another question for you, Pat, on the issue of time and range. So this is what Mariana from JDRF was discussing, right? So the hemoglobin A1C, which is that measure that's kind of the standard of care now. She explained every 3 months you go, you have a blood test, it's measured, it's an average. So as she pointed out, you could have, some really good days and bad days, but it could look fine, a 3-month average. And that time in range is a, hourly, daily measure that really says, are you in the red or are you in the green zone? So it says, has Prime looked at time in range as an outcomes measure of interest? And then again, I think you already spoke to this part, would you be interested or open to looking at the digital therapeutic data as a predictor, this is interesting, predictor of adherence, patient engagement, and medical resource use outcomes?
Yeah, the short answer is yes. And we look at the clinical trial data for time and range. So it does influence the therapeutic formulary decision making. So short answer, yes.
Okay. Great. Erin, I'm just curious, has this come up, this issue of time and range for patients with diabetes come up within DC Medicaid at all yet?
Not directly. I mean,
okay.
It's important to remember that and devices are, in a bit of a different class, but, for the most part, we strive to cover, everything on that's approved by FDA, right, with the rebates with Medicaid programs. So, it creates sort of a different, some innovations create sort of a different fiscal pressure. But I think that the ability to actually bring in some of the device data in addition to what we can see from claims and more clinical interactions is a great opportunity.
That's great. So there was a comment for the earlier panel that I wanted to acknowledge, and this one is probably more for you, Erin, than Pat, since Pat, I know you are, prescription therapeutics and some associated devices, and this one particularly was giving an example related to DME, durable medical equipment, for our acronym check there. And the comment was really, how do payers think about the difference in value when we're talking about, say, a prescription drug versus a wheelchair for someone? A wheelchair doesn't cure anything, right? It is a tool that patients with certain conditions need to maintain functionality and quality of life, but it is not an intervention in the same way a drug or a surgery or something else might be. And the question really was, how do payers think about the difference in value, or is there any way, do you think about those things differently with respect to coverage and payment and access?
Yeah, it's an interesting question. I mean, I have to say that's out of my swim lane, but I think it's a really interesting consideration to think about against where the data is that is driving those determinations. I would just say that as a very large public program, we are consistently addressing fiscal pressures, right? We have one of the most supportive executive and legislative, groups in the country. The mayor is extraordinarily supportive of the Medicaid program, as is the DC Council. And we still, face challenges with respect to, funding and supporting the range of services and therapies that we would like to. So, I think it's just an ongoing conversation that we have to continue to have.
I appreciate that. I wanted to just reflect on one other comment, pivoting back to digital therapeutics, since one popped up in the Q&A here, and I know we have a few more minutes. So the comment is, agree that digital therapeutics has promise for better capturing patient data, but none of the discussions start or include patients and patient organizations. So if you're reflecting on the comment, if you're not at the table, you're on the menu. How can we ensure that this new bastion of data collection focuses on the most important elements from patients? So I think we have consensus that digital therapeutics is, the advent is a great development, but I think some concerns about how do we then make sure when we're utilizing that tool in the toolbox that it's still patient-centered. So Erin, do you want to try that one first, or do you want to pass it to Pat?
I'll give you a chance to go first.
So having evaluated and worked with some digital therapeutic companies, I would encourage the patient advocacy groups, patient preference groups, to reach out to them. I would envision that they'd be very interested in working with you. I would be disappointed if they weren't. And you can say that I've asked you if that's going to be helpful in any manner.
Pat said I should, right?
Yeah, the payer, Pharma Therapeutics payer would like you to. But I mean, for example, I'll just say that we have a value-based purchasing agreement with the digital therapeutic in the marketplace right now as a press release for, digital therapeutics, they themselves have a price to value as well. And we want them to be used. So we are encouraging coverage, and one process to do that is to contract around outcomes. And so the outcomes we've contracted around right now are we would say that they aren't the patient preference outcome. Love to have that, and if it's included in data collection of a digital therapeutic, then we can contract around that.
That's great. Thank you, Erin.
This is why I was hoping you'd go first, Pat, because I think that was a great approach to the question. I will just add that as a payer and one who thinks about value-based payment a lot, we really want to use a framework and align in a multi-payer way. Ideally, we need the data to do it, right? And if we can find some proven strategies that advance, have a common framework, right, for assessing value, that's what's easier to do. And so one thing that I hope folks have had a chance to take a look at, or maybe IVI can share if folks haven't seen it yet, is the new Centers for Medicare and Medicaid strategic plan or white paper innovation center.
Great suggestion. Yeah.
Because it really, I think, identifies and touches on many of the comments that the first panel did. And it's really nice to see CMS saying, look, in our next 10 years, we really want to see these accountable relationships. We want to make sure that a broader range of data is used to drive outcomes, including patient-reported measures. They focus on patient-reported outcome measures in particular, but my sense is it's the broader experience. And again, they recognize that there is friction, perhaps due to churn, with the high rates of coverage that we have now. But I think more importantly, just there's going to be fluidity in terms of coverage. And so when there's friction between coverage between different payers within a marketplace, it's very difficult to gain traction with providers, right? So I just want to make sure that I had a chance to kind of bring that at the end, because I think again, what was talked about this morning is very much in line with this new strategy that CMS has released, and I hope folks will take a look at it.
Erin, that's a great suggestion. I appreciate you raising that up. I think, payment for better, for worse, drives practice. And CMMI, the Center for Medicare and Medicaid Innovation within the Department of Health and Human Services, is leaning in, as you note, on really pushing to evolve the healthcare system even further and focusing not just on value and outcomes, but patient experience and equity. There's a key component that's woven. It's a thread throughout all of it, which is we have to ensure that what we are doing is equitable. We're addressing disparities, and we are advancing what matters most to patients. So thank you for that. And thank you, Melanie, for putting the link to the CMMI report in the chat. I should also mention they hosted a 1-hour kind of town hall discussion, which was recorded. So if you don't want to slog through the whole report, you can listen while you're walking your dog or taking your kids to the park or whatever you might be doing. It's worth a listen to hear the leaders of the agency talk about where they're going. And as we know, with the federal government being such a huge payer, as you note, Erin, that will certainly help drive change within the healthcare ecosystem. We have 2 minutes to go. And since it's my job to keep us on time, I can't have us run over. So I did want to just give you a chance for each a brief closing comment. If there's something you want to, a call to action to everybody who's listening today. As you know, we have a range of stakeholders here, and welcome you giving people a homework assignment or recommendation. So Erin, you'll go first, and then we'll close it out with Pat.
Great. Thanks again, Elisa and Pat. Great discussion and excellent questions. Thanks, everyone. So, I just want to close with something near and dear to my heart. I sometimes say that my deep, dark secret is that I helped to write the privacy rule way back when. And so I just really think that what's essential to a lot of the patient engagement issues and the data issues that Pat talked about, what's at the core of both of those is better access to consent and to consent tools. And I just want to, give folks sort of the homework assignment and to sort of keep faith that I think that with some of the regulatory changes that have been made recently, again, particularly with the interoperability and patient access rule, there are more and more opportunities to allow patients, caregivers to express their preferences for sharing data, including for research and evaluation. We really need to lean into those, as well as supporting national data standards, because again, the more we can get information into this sort of utility model that I described, the better job we can then do expressing new measures that will get at all these core concepts. So again, I know that a little bit further down the field, folks, but Dana talked about going upstream. And I think this is a key area where, as IVI is thinking about reflecting comments on what we can really do, there's some key things we can do to get the right data into the system that expresses patient preferences and make the measures better in the long run.
Great. Thanks, Erin. Pat, call to action, closing thought.
Sure. Oh, I think I'm not on. You can hear me okay? Okay.
Yes, we can hear you. Yep, all good.
Apologies. It's been thank you for inviting me. I'm actually most here to learn, not to put a call to action, but I'll just ask that the creation of measures that can be standardized across conditions is incredibly beneficial. Having disease-specific measures of quality of life, of preferences that cannot be compared apples to apples against another condition is just challenging for us. So the more that the patient advocacy groups and other organizations can work together to create standardized measures, for example, for pain measurement, other quality of life, activities of daily living, and those types of measures that are standardized, I ask that you try to do that. Thank you.
Great. Thanks, Pat.